This is the second video session on lung cancer for third-year medical students. We are speaking about risk factors for lung cancer. So smoking, radiation, asbestos exposure, industrial exposure to nickel, chromium are very important risk factors for the development of lung cancer. However, they are not the only ones. There are more other risk factors, but these are the important ones for your exam. Smoking is a very important risk factor for the development of lung cancer, so please be aware, guys. 90% of lung cancers occur in active smokers. Passive smoking is also a risk factor for the development of lung cancer. It can still increase the risk of developing lung cancer, yet less than active smoking, of course. And for unknown reasons, women are more susceptible to carcinogens in tobacco smoking than men. The other important risk factor is radiation, asbestos exposure, and there is a synergistic increase in the risk of development of lung cancer. Synergistic increase in the risk of developing lung cancer if we combine asbestos with cigarette smoking. So cigarette smoking alone is a risk factor. Asbestos alone is a risk factor. If we combine both of them, then we are having a synergistic increase in the risk of developing lung cancer. The frequency of lung cancer increases with increasing the number of packs and years of cigarette smoking. For example, smoking of 2 packs a day for 20 years will have 60 times increased risk of developing lung cancer compared to non-smokers. So keep this in mind when you are speaking to people who are smokers. Tell them that 2 packs a day for 20 years will make you 60 times more liable to get lung cancer compared to a non-smoker. Cessation of smoking will decrease the risk of developing lung cancer over time. However, the risk will not return to baseline levels. Genetic changes that predate the full development of lung cancer can persist for many years in the bronchial epithelium of former smokers. And we are going to speak about this in more details in a while. Pathogenesis. Carcinomas of the lung arise from sequential accumulation of mutations in tumor suppressor genes. So similar to cancers elsewhere, we need a sequential accumulation of mutations in order for cancer to develop. So for example, in lung cancer, at the beginning, there is a mutation in the tumor suppressor genes. This will be followed by mutations in proto-oncogenes. Then lung cancer will develop. So, for example, this is a picture of the short arm of chromosome 3, and there are many tumor suppressor genes. It was found that deletion of the short arm of chromosome 3 is associated with high risk of development of lung cancer. It is found also that the deletion of these genes from chromosome 3 is present in the epithelial cells even before they change to malignant cells. So this is an important thing to put in mind if we want to screen for cancer in advance. So, short arm of chromosome 3 deletions are detected in almost 100% of small cell lung cancers and more than 90% of non-small cell lung cancers. These changes appear early in the pathogenesis of lung cancer, as I told you. They are found in the smoking damaged respiratory epithelium. So in the damaged respiratory epithelium, the respiratory epithelium that is damaged by smoking, if we take these cells and examine them, extract DNA from them, and check for chromosome 3, we are going to find that there is a deletion in the short arm of chromosome 3. Just to remind you, this is a chromosome. So assume one of them is the short arm, the other one is the long arm. This is the short arm. Then if this short arm of chromosome 3 is deleted with all these tumor suppressor genes, because they are tumor suppressor genes, then the patient is more likely to get tumor. It's found that smoking will affect the respiratory epithelium. The respiratory epithelial cells will show chromosome 3 short arm deletion. This thing will be found in the histologically normal epithelium as well as the epithelium with histological changes of pre-neoplasia. So the normal epithelium will still show these abnormal deletions. In addition, the epithelium that has got the pre-neoplastic histological changes, for example, the metaplastic epithelium, will still show these changes. These 3P genetic alterations lead to a conclusion that the short arm of human chromosome 3 contains several tumor suppressor genes. So during the development of lung cancer, several growth factors and receptors will become activated because of mutations in proto-oncogenes. As I told you before, we said that carcinomas of the lung arise from sequential accumulation of mutations in tumor suppressor genes and oncogenes. We discussed tumor suppressor genes, which are on the short arm of chromosome 3. This is an early event. A later event will happen related to proto-oncogenes, activation of proto-oncogenes. So regarding the oncogenes, which are the following step required to develop cancer, during the development of lung cancer, several growth factors and receptors will become activated because of a mutation in a proto-oncogene. So these growth factors and the growth factors and all the growth factor receptors will be activated because of a mutation in a proto-oncogene. One such proto-oncogene is KRAS, which is part of a signal transduction pathway. So imagine this is a proto-oncogene, this is a proto-oncogene. KRAS is a protein which is important for signal transduction. So if this protein is always activated, then there will be always signaling, and then there will always be activation and cell proliferation. Point mutations in KRAS are seen in 15 to 20% of non-small cell lung cancer, and they are frequently associated with tobacco smoking. A second example of proto-oncogenes is the EGFR, epidermal growth factor receptor. So epidermal growth factor receptor is a receptor that's composed of three different domains: ligand binding domain, transmembrane domain, and a kinase domain. When the epithelial growth factor protein binds to its ligand binding domain, this will lead to activation of the kinase domain. Binding of EGF to its receptor will cause activation of kinase domain through binding of ATP. ATP will bind to the kinase domain, causing its activation. If there is a mutation in the kinase domain of this receptor, this will lead to the receptor being always activated. Again, if there is a mutation in the kinase domain of EGFR, which is seen in patients with lung tumor, this mutation will turn this kinase domain always active. That's why, to treat this condition, EGFR inhibitors or TK, tyrosine kinase inhibitors, like gefitinib or erlotinib, can compete with ATP, binding here with the kinase domain, and this will prevent downstream signaling and will stop signaling. So this is one of the medications that are used to treat lung cancer. But the response to this medication varies between patient to patient. Histological types of lung cancer. There are, as I told you, there are two main categories: small cell lung cancer and non-small cell lung cancer. Non-small lung cell cancers are further subdivided into squamous cell carcinoma, adenocarcinomas, and large cell carcinomas. So squamous cell carcinomas, they arise centrally. Every one of these we need to know where does it arise from? Is it central or peripherally? And histologically, how does it look like? So squamous cell carcinoma arises centrally or near the lung hilum, as you can see. Because it is centrally and near the lung hilum, it can cause erosion of the bronchi. This will produce cough, shortness of breath. Sometimes it can erode arterioles, leading to hemoptysis. Okay, if erosion happens and the tumor erodes blood vessels, then hemoptysis will happen. So cough, shortness of breath, and hemoptysis are the usual clinical presentation, the usual clinical features of squamous cell carcinomas. Histologically, they might be well differentiated, as in this picture here, or they might be poorly differentiated anaplastic. Regarding adenocarcinomas, adenocarcinomas are the most common type of lung cancer in women who are non-smokers and young people. It's the most common type of lung cancer in women, non-smokers, and young people. Adenocarcinoma. It appears as a peripheral mass. Peripherally, see? It is arising from the peripheral parts of the lung. And because it's arising peripherally, then it's less likely to produce symptoms compared to squamous cell carcinoma. Because in order to have cough and shortness of breath, you need to have irritation to the main bronchi or big bronchi. Because this tumor is peripheral and it arises peripherally, then the patient is less likely to develop symptoms compared to squamous cell carcinoma. It can also develop in the areas with prior inflammation. Well, histologically, as the name implies, it's adenocarcinoma, so these are malignant cells trying to form glands. The third other histological type of non-small cell lung cancers is large cell carcinoma. Large cell carcinoma, these are poorly differentiated, and they are aggressive tumors. They can arise either centrally or peripherally. So they can arise either centrally near the hilum or from the periphery. Either centrally or peripherally. And they lack the cytological features of small cell carcinomas. They lack the cytological features of glandular or squamous differentiation. That's why they are poorly differentiated. They are undifferentiated tumors. Large nuclei, prominent nucleoli, moderate amount of cytoplasm, as you can see here. And this tumor is really bad. It has a poor prognosis. And it is an aggressive tumor. So, what about small cell carcinomas? These are also called oat cell carcinomas because of their resemblance, because of their resemblance with the oat grains. As you can see here, the malignant cells resemble the oat grains. That's why they call it oat cell carcinoma. Okay? So small cell carcinoma, oat cell carcinoma, usually central or hilar. It could be central or hilar. Central or hilar. So it is mainly central or hilar, which means the same basically. It's all near the center. Strongly associated with cigarette smoking. It is a neuroendocrine tumor. And what does neuroendocrine tumor mean? It means that this tumor originates from the neuroendocrine cells that are present in the bronchial epithelium. So neuroendocrine tumor means it originates from neuroendocrine cells of the bronchial epithelium. There are neuroendocrine cells in different parts of the body. If a tumor originates from neuroendocrine cells in the bronchial epithelium, then this is small cell lung carcinoma. So, because it's a neuroendocrine tumor, then there are two main features. The cytoplasm will contain neurosecretory granules, and some of these tumors will secrete hormones like peptides. For example, parathyroid hormone-related protein can be also secreted from small cell carcinoma, leading to symptoms which are called paraneoplastic symptoms or paraneoplastic effect, and we will come to this in a while. The malignant cells will stain positive for neuroendocrine markers on immunohistochemistry. So as I said, small cell carcinoma or cell carcinoma, microscopically, malignant cells are, let me correct this, microscopically, malignant cells are small, as you can see. Malignant cells are small, round, oval, scanty cytoplasm, hyperchromatic, prominent nuclear molding, absent nucleoli. Malignant cells are arranged in nests. So as the name implies, small cell carcinoma, small cells, round cells, scanty cytoplasm. As you can see here, it's very clear, scanty cytoplasm, absent nucleoli, arranged in nests, while adenocarcinoma, as you know, was arranged in glands. These are arranged in nests with loss of architecture of the bronchial epithelium, as is obvious from here. These tumors tend to metastasize. They have high tendency to metastasis. You have to keep this in mind for your exam. Small cell carcinomas have high tendency to metastasis. Okay? Rapidly growing, high tendency to metastasis, and usually the patient will present with metastasis. Clinical features of lung cancers. Some of them are asymptomatic and discovered incidentally while doing routine chest X-ray or routine exams. And as I told you before, asymptomatic patients, where do we see asymptomatic patients? If you remember, those with adenocarcinoma or any other lung cancer that develop or that arise in the periphery might be asymptomatic. So asymptomatic patients who are incidentally discovered during routine tests, this is a group of patients. Some of them will present with effects of local pulmonary spread, local intrapulmonary spread. This is due to local invasion to the lungs and bronchial tree. So those patients will present with cough, hemoptysis, shortness of breath, features of airway obstruction, and we will come to this in a bit. Some will present with weight loss and fatigue. Some patients might present with effects of local invasion. This means that the tumor will invade locally invasive. For example, a tumor might invade the recurrent laryngeal nerve, causing hoarseness of voice, or ribs, causing rib destruction, or the esophagus, leading to dysphagia, or the pleura, leading to pleural effusion, and we will come to this later on in this session. Some patients might present with paraneoplastic effect. Paraneoplastic, which means symptoms which are not neoplastic, but they are because of cancer. These are signs and symptoms which are not because of the cancer itself, not because of metastasis, not because of the local invasion, and not because of metastasis. They are called paraneoplastic symptoms or paraneoplastic syndrome, and we will come to this later on. So some of them, as I said, will present with effects of local intrapulmonary spread. For example, if a lesion is here, then it will press or invade the major bronchi, leading to cough, leading to hemoptysis, especially if it invades vessels. And hemoptysis can be massive and can be fatal. So please do not underestimate hemoptysis in a patient who is elderly, smoker, with hemoptysis and cough. Do not underestimate hemoptysis, please. Hemoptysis by itself might be fatal. Okay? Some of them are asymptomatic, especially if the lesion is peripherally, adenocarcinoma, as I told you. So features of intrapulmonary spread: cough, shortness of breath, and hemoptysis. Cough, shortness of breath, and hemoptysis. What else? What do we have? Features of intrapulmonary spread. Local intrapulmonary spread, we might have features of obstruction. If the lesion obstructs the main bronchus, then distally it will be difficult to clear the secretions. This will lead to accumulation of secretions. This might lead to pneumonia. This might lead to lung collapse. This might lead to lung abscess. So, in an elderly smoker presenting with pneumonia, carcinoma needs to be excluded. Please, this is an important note. An elderly smoker presenting with pneumonia, carcinoma needs to be excluded because you need to think about carcinoma that causes obstruction of the major airway or large airway, leading to pneumonia. Okay? So, in this case, by examination, we are going to find features of lung collapse, total lung collapse, or a whole lobe is collapsed, distal pneumonia, fixed monomorphic wheeze. Fixed monomorphic wheeze. This is a wheeze that is fixed because the tumor will cause the tumor that causes obstruction will cause turbulence in the blood flow, but this turbulence is fixed. So the wheeze will be monomorphic, unlike asthma where the wheezes are polymorphic. Now we are going to discuss effect of local invasion. Effect of local invasion. If the pleura is involved by the tumor, then we will have pleural effusion. If the esophagus is involved, then we are going to have dysphagia. If ribs are involved, rib destruction. Recurrent laryngeal nerve. Look at this tumor. This is a tumor affecting the apical part of the lung, invading the recurrent laryngeal nerve, causing hoarseness of voice. Sometimes we have Pancoast tumor, which is superior sulcus tumor. This is tumor in the upper portion of the upper part of the lung, in the apex, apical tumor, called Pancoast tumor. This tumor can cause Horner syndrome. This is important for your exam, and you need to be aware of it. What is Horner syndrome? Horner syndrome is Pancoast tumor causing a syndrome. What is this syndrome? Enophthalmos, ptosis, meiosis, and anhidrosis. In order to remember this syndrome, remember this nice statement. Horner is a guy whose forehead is dry forehead because of anhidrosis, who has a small eye means meiosis or enophthalmos, and can't see the sky because of ptosis. So enophthalmos, ptosis, meiosis, and anhidrosis. All of this is because of cervical sympathetic plexus being invaded by the local tumor. Those patients will also have shoulder pain. Okay? There is another mnemonic for Horner syndrome, which is called SAMPLE. SAMPLE. S stands for sympathetic chain injury. A stands for anhidrosis. M, meiosis. P, ptosis. L, loss of ciliospinal reflex. And E, enophthalmos, which is pseudo-enophthalmos, of course. It's not like anatomical enophthalmos, it's a pseudo-enophthalmos. And we are still talking about effect of local invasion of the lung cancer. Okay, we said there is pleural effusion, dysphagia, rib destruction, hoarseness of voice. All of these are due to local invasion. Again, if the upper part of the lung is affected by the cancer, Pancoast tumor, there will be cervical sympathetic plexus affected. This is local invasion. What else? Local invasion. Superior vena cava obstruction. Superior vena cava syndrome. Compression or invasion of the superior vena cava result in facial swelling, congestion, blurred vision, confusion, and dilatation of the veins of the head, neck, and upper extremities. Excuse me. Sorry for that. So the tumor can invade the superior vena cava, and this will result in facial swelling, congestion, blurred vision, confusion, dilatation of the veins of the head and neck and upper extremities. So if you are an internal doctor, rotator, and then during your foundation years, you were called by the nurse, and if the nurse tell you that you are in the oncology department, and the nurse from the oncology department told you that, doctor, there's a patient with suddenly developed facial swelling, facial congestion, blurred vision, confusion. These symptoms in the oncology department, you have to always and always and always be aware of superior vena cava obstruction, superior vena cava syndrome. This is very important for your exams. Facial swelling, congestion, blurred vision, confusion. When you come to examine this patient, you found that he is having dilatation of the veins of the head, neck, and upper extremities. All of these are due to pressure on the superior vena cava, which drains the head, neck, and upper extremities. So any pressure on the superior vena cava needs to be considered as an emergency. This is a very important topic for your exams. This is an emergency condition. You have to call your consultant. If you are in your internship and the nurse called you about a patient in the oncology department with history of lung cancer, developing facial swelling, change in the color of the face due to congestion, blurred vision, confusion. On examination, you found dilatation of the veins of the head and neck and upper extremities. Then you have to call your consultant. This is an emergency condition. You should not miss this at all. This is very important for your exam. Treatment will be corticosteroids and emergency radiotherapy after taking a biopsy, or sometimes without even taking a biopsy. It depends on the guidelines of that hospital you are working in. The other important thing with lung cancer is paraneoplastic effect. Paraneoplastic effect. These are signs and symptoms in cancer patients which cannot be explained by local invasion or distant metastasis. So, group of signs and symptoms in a patient with cancer. These signs and symptoms do not fit with local invasion or distant metastasis. They call them paraneoplastic effect. Paraneoplastic effect is seen in 3 to 10% of all lung cancer patients. For example, patients with small cell lung carcinoma produce ACTH that leads to Cushing syndrome and ADH that leads to syndrome of inappropriate antidiuretic hormone secretion. Patients with small cell tumors, small cell lung cancer, with squamous cell cancer, they can produce parathyroid hormone related protein. This is a polypeptide. This is a protein, polypeptide chain, whose action is similar to parathyroid hormone. It can cause hypercalcemia through stimulating bone resorption and calcium reabsorption from the kidneys. So osteolytic lesions in the bones will be produced basically because there will be resorption of the bone. This will lead to hypercalcemia. In addition, calcium reabsorption from the kidneys. All of this because of parathyroid hormone related protein. It's not a hormone, it's a parathyroid hormone related protein. It's a polypeptide chain acting like parathyroid hormone. This is produced from squamous cell carcinoma, squamous cell tumor in the lung. So, what about secondary lung cancers? We've been discussing primary cancers in the lung, and we said that primary tumors of the lung are 2 major categories: small cell lung cancers and non-small cell lung cancers. The non-small cell lung cancers were subdivided into squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. Now we are going to speak briefly about secondary lung cancers. Secondary lung cancers are secondaries to the lung, metastasis to the lung. This is common because both carcinomas and sarcomas arising anywhere in the body may spread to the lung via the blood, via lymphatics, or by direct extension as esophageal carcinomas. The pattern of metastatic growth within the lung is usually in multiple discrete nodules. Multiple discrete nodules. Look, multiple discrete nodules. This is called cannonball lesions. They are scattered throughout all lobes, or it may be solitary nodule, but usually multiple discrete nodules, common cannonball lesions. So, how to diagnose a primary or a secondary lung cancer? After taking into consideration the clinical features of the patient, the age, usually more than 50 years of age, the peak is 75 to 79. Smoking, so elderly who is a smoker, presenting with cough, hemoptysis, shortness of breath, weight loss, wheezing, or sometimes with paraneoplastic syndromes, or sometimes with supravena cava obstruction, and all of the other clinical features that we have mentioned. With these clinical features, you have to put in mind lung cancer. So you need to do radiological tests, which are non-invasive ones, CT, chest X-ray, CT scan, MRI or PET scan. You need to do sputum cytology, take a sputum sample, send it for cytology. If the patient is having pleural effusion, then we can take aspirate from the pleural fluid and send it for cytology. Needle biopsy, if the lesion is peripheral, for example, the lesion is here peripherally, then a needle can be introduced through the skin and a needle biopsy is taken. If the lesion is more centrally located, then bronchoscopy and biopsy will be needed. Then after the biopsy will be examined histologically, immunohistochemistry, genetic molecular studies, and a diagnosis will be given. If the diagnosis is confirmed for lung cancers, then the treatment will be either surgical resection, which is usually done for localized tumors, non-small cell lung cancers, or radiotherapy and chemotherapy. Radiotherapy and chemotherapy can be given for the non-small cell lung cancers and for the small cell lung cancers. Usually, patients with small cell lung cancers respond better to radiotherapy, chemotherapy, compared to the non-small cell lung cancer group, who respond better to resection. And now, what are the important benign lesions? There are many benign lung lesions, but the most important one is hematoma, the most important one for your exams, and it is the most common benign lesion in the lung. This is called hematoma. The most common benign lesion is called hematoma, which is a spherical lesion. Spherical lesion. Okay, coin lesion. Sorry, spherical lesion, coin lesion. As you can see, it's a spherical, small, discrete lesion that often shows up as a coin on chest X-ray. Hematomas consist mainly of mature cartilage admixed with fat, fibrous tissue, and blood vessels in varying proportions. So it's cartilage and fat with fibrous tissue and blood vessels in varying proportions. Okay? So